Hello everybody. Today we are going to discuss about the acute kidney injury. So rifle classification scheme for the AKI. So risk is increasing creatinine by 1.5 times or the decrease in GFR by 20% or urine output criteria is less than 0.5 ml per kg per hour for 6 hours. Injury serum creatinine by for 2 times or decrease in GFR for more than 50%. Urine output criteria is less than 0.5 ml per kg per hour for 12 hours. Then failure is increase in creatinine by 3 times or decrease in GFR by more than 75% or serum creatinine value is more than or equal to 4 or acute increase in serum creatinine by more than 0.5 mg per dl. Urine output criteria is less than 0.3 ml per kg per hour for 24 hours or anuria for more than 12 hours. Loss is persistent acute renal failure or complete loss of kidney function for more than 4 weeks, and end-stage renal disease is end-stage renal disease for more than 3 months. Limitation of the AKI definition. The most obvious limitation arises from the nature of the stage. Based on the fact that it is the dynamic definition, the reference or baseline serum creat value is mandatory for determining the diagnosis and stage of the AKI. This means that patient with the known baseline serum creatinine can easily be categorized. However, this approach will not work in patient with the unknown baseline serum creatinine or even undiagnosed CKD. Furthermore, in patients with the CKD and baseline serum creatinine of more than 1.7, then this patient cannot be classified as stage 2, given the doubling of this baseline leads to the stage 3. To address this issue, various tools for assessing reference baseline serum creatinine has been created. Another limitation of serum creatinine is the interference of this marker by several factors. That is infusion of large amount of the fluid, for example, in the context of major surgery, may lead to dilution and subsequently the reduction of measured serum creatinine. This can affect its diagnostic value, especially in the detection of post-operative AKI. The misinterpretation of diluted serum creatinine value may lead to overlooked AKI, and adjustment in the serum creatinine just for volume balance are somewhat simplistic. Changes in the serum creatinine can also be caused by reduced creatinine production, which is common and critically in patients caused by muscle mass loss due to immobilization or as well as sepsis when estimated GFR and hence renal functions are overestimated. Furthermore, serum creatinine and urine output, these are the only surrogates for estimating changes of the ERGF. Also, the low sensitivity of serum creatinine is reflected in the observation that any increase in serum creatinine is not observed until after at least half of the GFR is lost. Consequently, small changes of GFR cannot be detected by serum creatinine level that small losses of GFR are associated with worse outcome. Cork et al. Demonstrated this correlation between the perioperative slightly rise in serum creatinine level, not yet meeting the AKI criteria, and increased mortality. The urine output has low specificity as it is influenced by several factors, including the use of diuretics and hypovolemia. However, despite this, the diagnosis of AKI based on urine output is also associated with adverse long-term outcome, and therefore, where possible, urine output should be used in diagnosing and staging an AKI as well as serum creatinine. From subclinical AKI to AKI. Functional biomarkers of renal function like serum creatinine and urine output show degree of latency when used for detecting impaired renal function. It takes time for serum creatinine to increase after impairment of kidney function. Consequently, efforts were made to accelerate the detection of kidney damage and impaired kidney function by finding biomarkers that detect the kidney stress and damage and can predict AKI both earlier and with more precision. In general, such a biomarker may be described broadly as either functional markers or damage markers. Functional biomarkers are surrogate markers of glomerular functional rate. Based on outline shortcoming, better functional biomarker are desired. These include cystatin C, which is not influenced by muscle mass or age, as it is synthesized in all nucleated cells. It shows greater sensitivity and specificity than serum creatinine for evaluation of renal function and has better performance in predicting AK. However, cystatin C concentration are influenced by autoimmune disease, steroid use, and cigarette smoking. Damage and stress biomarkers are released in response to stress or damage of the kidney cell. Neutrophil gelatinase associated lipocalin, tissue inhibitor metalloproteinase 2, and insulin-like growth factor binding protein 7 are novel damage or stress biomarker that have good performance in predicting AKI and can be measured at bedside by using point of care devices. Biomarkers for prediction of endpoints. The investigation surrounding new AKI biomarker evolved from seeking better detection of AKI to gaining deeper insight into pathophysiology of the syndrome. The combination of old and new markers has led to expansion of medical knowledge in this field. Damage and stress markers such as NGAL are associated with long-term outcome and allow more precise prediction of renal recovery and transition to CKD. Furthermore, adverse renal event, including major adverse event at a day 90 and development of CKD, are linked to kidney stress or damage even though no AKI was present. For better comparability of clinical trial investigating AKI and renal outcome, consistent endpoints are needed. At a result, endpoints like major adverse kidney event consisting of mortality, need for dialysis, and persistent impaired kidney function were developed. However, this endpoint was developed for treatment trial in which patient already have an AK. The strong correlation between damage biomarker and major adverse kidney event outcome highlight the importance of the implementation of further diagnostic tool for long-term prediction in the clinical routine. However, in prevention trial, major adverse kidney event cannot be used because the event rates are too small. Therefore, other renal endpoints like occurrence of moderate to severe AKI, reduction in EGFR decline are preferable. The pathophysiology of AKI is complex and depending on its cause. Various mechanisms are involved, including inflammation, hypoperfusion, ischemia, and hypoxia. As stated above, TIMP and IGFP are two markers which are involved in the cell cycle arrest of tubular epithelial cell and release in the urine in the context of kidney stress. Both markers correspond with the renal cell stress. It has been shown that these two markers increase 24 to 48 hours before an AKI diagnosed on the functional biomarkers occurs. Additionally, increased levels correspond with the risk for need of renal replacement therapy. Given these patients with the need for RRT, they are at increased risk of developing persistent dialysis dependency. Such a knowledge allows triage and optimal utilization of resources. TIMP and IGFP showed high sensitivity and specificity in recent studies, and implementation into clinical practice is currently investigated. The neutrophil gelatinase associated lipocalin, that is NGAL, which is released by activated immune cells and damaged tubular epithelial cells. So NGAL exists in different isoforms which are quite specific for the tissue. It might be that NGAL can also act as growth factor being active in many different tissues. Mishra et al. Demonstrated the upregulation of NGAL in renal tissue after ischemic injury. This was associated with increased NGAL level in both plasma and the urine. Pro-inflammatory chemokine, C6 motif chemokine, that is ligand 14, demonstrated in patients with already established AKI, showed good performance in predicting a worsening of kidney function. A recent Ruby trial demonstrated that elevated level of CCLA14 correlates with the persistent AKI and thus renal non-recovery. According to their data, urinary CCL14 value of 1 to 3 Ng per ml or higher was unable to identify patient at risk for persistent AKI or future adverse events. As ongoing study is currently investigating whether CCL14, based on implementation of supportive measure, can reduce the improved renal outcome. The WNT and beta catenin signaling protein DCOF3, that is DKK3, also shows potential. Schul et al. Showed that perioperative measurement of urinary DKK3 in patient undergoing cardiac surgery is able to predict postoperative AKI and associated with long-term kidney impairment. Now, requirements of new biomarker. The application of biomarker to expand the identification of AKI will allow clinicians to identify AKI precisely and allow personalized approach. For example, recent work concluded that biomarker-guided categorization of AKI into subphenotypes hold many advantages. By classifying these subphenotypes, one may identify response to certain intervention and also biomarker expression. Using such an advanced classification of AKI has proven to be beneficial for highlighting those at high risk. For example, distinguishing patient with AKI developing CKD, patient with or without subclinical AKI developing CKD, and patient with CKD who experience progression. Nephron loss, glomerular hypertrophy, interstitial inflammation are associated with fibrosis and therefore should be prevented. So, biomarkers guided research may hold huge potential to identify causes for such unfavorable trajectories. New biomarker need to provide additional relevant clinical information. Differentiation of various AKI form, early detection of AKI, assessment of AKI severity, and monitoring of AKI treatment are promising advantages when using novel biomarkers. New biomarkers must also easily accessible for clinical routine. Only if biomarkers fulfill this prerequisite, then they will experience wide application and improve the care of patient at high risk for AKI or already established AKI. So, origin and the function of most promising biomarker in the AKI. So, for proximal tubular cell, there is KIM, L, a liver type fatty acid binding protein, then alpha glutathione S transferase, nitrotin 1, alanine aminopeptidase, alkaline phosphatase, then uh, uh, then this gamma glutamyl transpeptidase. Tubular cell in general is TIMP and IGFP, DKK3 and NGAL. Distal tubule cells is glutathione S transferase. Various renal tissue is monocyte chemoattractant peptide 1 and proenkephalin A. Non-renal tissue and circulatory cells are serum creatinine, cystatin C, proenkephalin A, CCL, cal protein, and interleukin 8, and then urine. So now we'll see what is resistive index. Resistive index of all the major parameter in nephrology, none is more misunderstood and misused than renal resistive index. Resistive index is typically measured by Doppler sonography in intrarenal artery and the difference between peak systolic and end diastolic blood velocities divided by peak systolic velocity. Any physiological and pathological influences that affect relative flow velocity at diastole and systole will change the value of resistive index. Emerging initially as a measure of renal function in patients with renal artery stenosis. Renal resistive index was assumed to be associated directly with altered, altered resistance to flow within the kidney and with range of renal pathological structural changes. However, subsequent experimental and in vivo studies have demonstrated that renal resistive index is more closely associated with several systemic factors. So for this, the use of renal resistive index is useful indicator for renal disease has been challenged. However, in recent studies, the renal resistive index has been shown to be affected by number of extrarenal factors that explain the observed value of renal resistive index as strong prognostic indicator for patient with renal damage and potential predictor of AKI. So, systemic factor, how renal resistive index affected by the blood pressure. The observed relationship between renal resistive index and components of the blood pressure are consistent with the theoretical understanding of RRI and offer some insight into how this systemic factor may result in renal injury. General population studies and studies of hypertensive patients demonstrated a somewhat surprising but consistent inverse relationship between RRI and mean arterial pressure that appear to be independent of other covariates. So this is not a direct indicator of renal function. So reduced MAP over time would be consistent with pattern of poor renal function. This suggests that in this patient, other factors affecting renal circulation may have more dominant role in renal resistive index. Now, influence of pulse pressure on renal resistive index. A key determinant of the pulse pressure is the compliance of large artery. In normal patient, as blood is ejected from the heart, expansion of aorta effectively dampens the pulse. So this effect contributes to the maintenance of continuously steady flow to the kidney. Where compliance of aorta is reduced due to vessel wall stiffening, this damping effect is absent and the renal microvasculature is exposed to high pulse pressure. Now, relationship between RRI and cardiac output. Normal renal function is dependent on the constant blood supply, which is in turn dependent on the cardiac output. So, renal autoregulation is essential in maintaining stable GF. The heart and kidney also play a closely associated role in maintaining hemodynamic stability, and severe dysfunction in either of these organs is unlikely to occur in isolation. So the amount of blood available to the kidney is dependent on total blood volume and on left ventricular output. So the Doppler assessment of left ventricular outflow tract, and transmitral peak velocity demonstrated significant association of RRR with central pulse pressure and left ventricular systolic and diastolic Doppler blood flow indexes. Altered cardiac output in critically unwell and acute presentation is likely to be more significant than this study suggests. This could be particularly relevant in older patients presenting with reduced left heart function in combination with hypovolemia and vasoplasia associated with fluid loss or sepsis. So there are systemic determinants of renal resistive index associated with renal function decline. So any systemic blood pressure will cause increase in the renal resistive index. Any increase in the central pulse pressure will cause increase in the renal resistance index. Increase in the systemic arterial stiffness will lead to the increase in the renal resistive index. And this all this effect will cause microvascular trauma over time and will reduce the functional risk. So left heart failure, that is decreased flow LVOT, will then reduce MAP, and bradycardia will increase renal resistive index, and all of these changes will cause long-term hypoperfusion, which lead to the ischemic damage. Now, acute determinant of renal resistive index associated with renal functional loss, that is hydronephrosis, acute inflammation, edema, and hematoma, will cause increase in renal resistive index. Then any condition associated with trauma, rhabdomyolysis, renal vein thrombosis, hypovolemia will lead to the increase in renal resistive index. Thank you guys.